various categories of hurricane preparedness that people can then link to, to create a written plan for themselves, their families, or even their neighbors, friends, communities, so everybody can work together to create a written plan so that when a disaster looms, they can make those decisions, but also a whole section on helping your neighbor, which, again, is very important, and that's been highlighted in this conference for the last couple of days. There's also very good weather information from FEMA. FEMA has a lot of good hurricane preparedness information, and I don't have the ability to play this video, but there's an actual video right on the FEMA website in their hurricane section that shows a video of storm surge coming in, and it is one of the most amazing storm surge videos I've ever seen. And if that doesn't motivate a person to evacuate, I don't know what will. So if you want to get somebody motivated to evacuate, 2 minutes, good. Then show them this video. So the FEMA website has very important information on sheltering and on storm surge and how to stay informed and at different actions that can be taken at different lead times. So when the hurricane is threatening, a hurricane is 18 to 36 hours from arriving, 6 to 18 hours, and within 6 hours. So again, a person can access this information and come up with this written plan for themselves, their neighbors, their friends, everybody, so that they can be ready for the disaster. And then there's information on what to do during the storm and after the storm. So again, we in the federal government have a lot of good resources, not only to prepare for the disasters, but of course in the National Weather Service we have a lot of resources when the threat looms, when the hazard is in the radar, so that you can then enact that plan. We also have storm surge predictions. So you can access storm surge predictions from the National Hurricane Center, and there are also inundation maps for planning purposes. So not only in Puerto Rico, but in anywhere in the continental US, there are flood inundation maps so that you know what category hurricanes will flood what areas along the coast. And I should also say, in closing, that once the disaster has occurred, we send out teams to do what we call service assessments. And we have, in the last 5 or 10 years, we've included a lot of social scientists within those assessment teams so that we can improve our messaging and understand why people made their decisions. So again, we in the federal government are into the social science, and this is just sort of, this is our role in the whole preparedness and response process. So I thank you for your time.
Thank you for the presentations, and I would like to ask our panelists to please take a seat in the front. So I'm going to ask some specific questions, and then in the later part, we're going to open the session of questions to all of you. So my first question for the panel, and I'd like to thank you for all your excellent presentations. We have a variety of very important areas of the disaster. We have the emergency managers, we have working with the community, we have team dynamics, and we have the weather forecast. So first question is, how should government and local communities and researchers work together to decrease the health impact caused by disasters? And who also needs to be at the table? And when we say health impact, we're talking about maybe morbidity, mortality, and mental health. So Seth, you want to take a first shot?
First shot. So who else needs to be at the table? I think when we put together our team, we put together a multidisciplinary team, but we still had some things that were missing from that, and we weren't a response team. We were working on recovery, so that's important. But I think going to the logistics challenges that were identified, and I worked in emergency logistics for a number of years, and so I know how important it is to have the right support with you, so you can be free to not worry about things. So I think having all of those folks, but one of the things that we learned in New York City, and I think one of the comments was from one of the presentations that, oh, New York City, we don't, we do everything. We certainly make a substantial number of mistakes. We have a lot of resources, but we learn certain things from every response. One of the things that was significantly challenging for us during the measles response was the community engagement and community partner engagement for not just the health department's assets, but with other relationships within the affected communities that we were working with. And we piloted a engagement strategy, I think, which was very important, but especially in long-term recovery, it's important to be able to identify community resources to bring them into the fold, have a seat at the table, whether that's through the community organizations active in disasters or the volunteer organizations, the COAD and VOAD groups, but also the ad hoc groups that will show up depending on the emergency and depending on what kind of challenges that you're trying to solve. So having a good engagement strategy is really going to be important.
I'm just gonna add to that, because some of the communities have worked really hard time. I mean, we did some training on religious beliefs and vaccinations, and during that period, I found that the Curious Joel community down in Orange and Sullivan County are also in Brooklyn, but they actually piloted the hepatitis A vaccine back in the 1990s. So, they had built a really long partnership with that community. The community now participates in their tabletop exercises. And so, talking about mistakes, I of course went to shake somebody's hand and I'm like, oops, I wasn't supposed to do that. Person kindly treated me, but they've offered up they have their own ambulance system and they've offered it all up. So, but all of that takes the time to build those partnerships and those relationships.
I'd just like to second that tabletop exercise. Oh, is that on? Hello? Can you hear me?
Yes, we can hear you.
Yes, so, okay, that's good. But anyway, I'd like to second that tabletop exercise concept because, communities can only learn if they sort of enact a pretend disaster. They can figure out, what they need to improve. And we at the Weather Service are in that business. We try to participate in as many of those as we can. Dam emergency exercises, a lot of that. So also in the National Weather Service, we've made a point of collaborating with people like Shao, the University Public School of Health, also with the New York State Department of Health. We've actually worked with them on extreme heat and cold studies, and we actually changed the threshold for heat advisories based on some of the research. So those are important partnerships. But what's most exciting, well, maybe not most exciting, but very exciting, is that in 2021, our National Weather Service will be in the same building as the Atmospheric Science Department, the College of Emergency Preparedness, the Atmospheric Science and Research Center, and a lot of other great partners, so that we will all be under the same roof, and we will be working together on these problems instead of being in different buildings in different parts of the university.
I'll throw out, instead of just, who, because I think we all kind of know the who's, including the BOADs, which Central New York is, that's a big one. But the term of community engagement, and you need to realize that community, depending on its unique characteristics, will be different. That being said, what I would encourage people to do as a technique is, when a disaster happens, you're most probably going to be either become aware of or work with some different partners that you weren't expecting. The measles is a great example. Leveraging the religious leaders and the rabbis and some other stuff like that. but use that relationship that you gained during the emergency to build on that into the future. Now, you're not probably going to have some of these community partners, you know, coming to a once every month meeting for your emergency coalition thing, but once a year town hall, or invite them on a specific thing that is of interest to them. I think it would really, you know, build you a lot of money in the long run.
Thank you very much. Dr. Xiao Li, during emergencies, you know, some schools have thought about when is the best time to come and do research. So from the emergency side, we are like, okay, not now. You know, we're handling the emergency right now. So what are you doing, or what can researchers do to, you know, strengthen that relationship with the emergency managers and maybe get a seat at the table, and maybe just observing, you know, for a while, but eventually they can get out and do their work. And this is also for Seth and Mike to comment. How can we harmonize the effort?
Yeah, I think this is a good question. Because I'm the NIH grant reviewer for multiple time-sensitive grant. So I think, of course, after each of the big disaster, I think the NIH and some federal government agency will issue some special grant. So I think definitely it's the start early as possible is the better. But also, I think about one thing. I just try to be combined with the question. I think this last question is that we should just like the different. We should use the different the existing database in the state health department, because just I described there's so many data there, so we can just use those data. We be very quickly can start with a research, and also different layers of government should work together. One thing I want to just point out here is that based on our data, I think in the Hurricane Sandy, city health department and state health department do a great job, because we found multiple health outcomes even reduced after Sandy compared to pre-Sandy time, like cardiovascular disease, and also we found injury and waterborne foodborne disease. So because I think that's the department health, I think the great contribution. They work timely and very effectively to provide some, I think it's 1 million hot meals to the residents and the waters, and also provide, I think it's more than, I think couple hundred for the medical centers and the resilience, I think disaster centers. I think they do a great job. So even we found really surprised by when we look at the Medicaid data, a lot of health outcomes even reduced. So this shows the public health, the power. So if we prepare early and effectively, even we definitely can avoid all this disease burden.
Yeah, so there was a note that I had about following up the show about syndromic surveillance. We, in New York City, we have a pretty robust syndromic surveillance system that looks at keyword, chief complaint, and then discharge diagnosis, ICD-10 codes. And it's, we use it for lots of different syndromes every day. The ones I get emailed to me, they're automated now for cold-related illness, carbon monoxide poisoning in the winter, as well as heat-related illness for both EMS call data as well as just hospital ED admissions or ED visits. It's fairly sensitive, and it signals for us when we should be concerned about something. For heat, it's really interesting. We can use that to gauge our posture as a city. For cold-related illness, we don't really have a way to ramp up a response for that. And I think a lot of that's due in part by the housing regulations that we have in the city, the heat regulations. But it's really interesting, you know, looking at some of your data that you showed from the health survey, we might be able to look at other signals or syndromes that could be created that may have the sensitivity to pick things up for emergencies. So I think there's a collaboration among the, you know, when we have a fairly robust research capability in-house, but also looking externally. The other data system that we don't normally release is data from our poison control center. New York City is one of the only municipally based poison control centers in the city, in the country. gets about 66,000 requests for service a year. It's a fairly robust ability to detect geospatial groupings of poisonings and other related things. We were seeing concentrations of opioid overdoses in some of the collection. So I think there's some work to be done there in the preparedness space. I'm not sure at sort of what time is appropriate to bring folks in. But we can always learn from emergencies, and one of the things that Mike mentioned before, and I also touched on with the Empower data, we went to try and use these data recently, and one of the problems that we saw is that yes, it's divided into folks who are ventilator dependent and folks who might have home dialysis. The coding on the CMS data didn't allow for the specificity to understand, well, is someone actually mechanically ventilated, or are they on CPAP or BiPAP for sleeping, for sleep apnea? So there's some work to do to parse some of that data to make it more useful in emergencies, so we can action it.
Can I ask a question about the Empower? Because I've been wondering about California and how they dealt.
We actually have a call with them scheduled for, I believe in the next month, to talk about their experience in wildfires and to couple our experience in Colorado.
I've been wondering about it, like what?
Yeah. Well, thank you for those responses. I would like to open the next few minutes for you, for the audience, to ask any specific questions.
Thank you.
Anyone?
Go ahead.
We have a mic.
So, I think you can hear me. So I'm a student from Puerto Rico. I was born and raised in Mayagüez. And I initially heard Primo and had a question regarding why weren't there task forces deployed to the west area? After seeing some of the maps, I can figure out why I targeted the east side. But even then, I like the recommendations that first you gave and then you presented, that the task forces maybe should include people specialized or trained in data management and logistics, so that even physicians in that situation don't have to worry about their record keeping, because in itself it's not the best environment to be operating or dealing with this type of situation. And while that would probably present hindering on your budget or your resources, because it would be more people you will have to deploy, maybe that could be resolved through partnerships with maybe state universities, having like student volunteers that already have worked as scribes, or maybe engineer students who are familiar with coding and data management, that can be easily resolved that way. So I think it would be a good change to bring about.
Yeah, I think by doctrine, each of the teams that I was referring to from HHS, and we didn't do a good job in replicating it. I think more because of, I don't know the reason why, but my opinion is every team should have a logistician,
Yes.
and they should have, whether you want to call it an informatics, IT, communications, data, whatever, someone that can do that. The third person that you need that could be shared would be someone designated as the leader. So they know that Mike is the leader for that team. And that can be shared with a doc, or emergency ED docs are great for that because they're really already into that. Public health people sometimes, they don't like to make a decision at the time and they want to work all together, which is awesome. However, there's sometimes when you just got to say you got to go. And some people just don't have the right personality for that. So, a team lead, a data person of some type, a logistician, and then your clinicals. Because, so I don't know if you read my bio, but before I did this for 17 years, I did 21 years active duty Marine Corps. And we used to kid around and say, tactics is for amateurs, logistics is for professionals. And that's the truth. And Puerto Rico is really, really hard. It's an island, it's far away, the port disappeared, the airfield disappeared. How the hell do you get this stuff there? Apologize for swearing. How do you get this stuff here? That was a really big, really hard logistics problem. So, and it takes some time on those things, but I agree with your comments.
So I think we don't have time for any more questions, and we apologize. But feel free to talk to our presenters after we conclude. So let's give a round of applause. Thank you for giving us your time.
John knows how to get home.
Yeah.
And there.
I'm gonna guess first.
Shout.
I was gonna call you out, but I was like, nah, you're-
The community engagement strategy for the custody population. I guess my question was that like an organized strategy in the very beginning, or is this like something that you sort of came together?
So
You know,
it's interesting,
organically?
yeah, so it may not be something that had been piloted, and talked about, right? So I guess it's changed a little bit, it's developed in certain areas. And so there was this, and so to leverage all of the partnerships, but really, yeah, we never worked with like the with a lot of
So yeah, we had
the cultural conferences are also some places so there were some things that were that were really down on one online calls they were also so it's like they were structured to make opportunities to help
Engagement strategy, that was like kind of like I can tell what you did, but I didn't know if it was like.
I think there's still work. Just had all the but it works. I am worried about and then all the inspections and all the out there. And we were tasked with so all the teams that they got scaled up and they got did audits.
You don't do that once a year.
No, it's a once a year. No, we do. There's an outbreak or a localized because they were all localized. So like inside will say, hey, they're everywhere. This was all the product.
Sorry. So one thing that surprised me, you know, for businesses is that as if the data about exclusion was my mindset was we always did that like October, November. So was it that they didn't work wrong?
Those are points.
In other words, you go to and you match and say, wait a second, you know, so they get vaccinated, and so, you know, correct that.
Redundant and multiple. Everything in the even like when we run statutory yes, they usually go on like that. They go on it so I always say at the start of school, next year, you gotta have some medical criteria for no one that just it works. How we can do this other problem? They're like, yes. When I saw the not a lot of information. We did the decisions that were made by the organization. And so at one point they were like, oh, well, IgG was okay, IgM was okay.
Well, now, good to see you.
And then the next week, that's when they changed it. So it became very hard for the legal process to.
No, I'm just surprised, because I thought like by November, the publishers have moved. So the initial publishing November, it wasn't quite as cool.
That's where you make
Based
your
on
money.
the press, it seemed that had happened in like November, December.
Well, and then there was a still hit the Ethier, there was a huge spike in December. And then in January.
We were on the fly, right? That's not the best way. We built them on the fly, so we still don't have it. I mean, but that was.
Did that performance?
Yeah,
no, yeah. This one was challenging, and this iteration of political leadership facing all this. I know. Yeah. And for her or him, there was a lot of there was a lot of challenges with it. Push us, close the school. Close the school. 5 minutes later.
We gotta do that.
When are you opening the school back?
And then you gotta put it together and try to.
Well, now it's further follow a statutory process to reopen. We're not pushing people. We're still getting
Hey, Dr. Set.
Oh, yeah.
I gotta run to my other.
Yeah. I saw you shot
Was it hard to do storage?
I don't. It was mostly. It was not a diagnostic center.
Oh.
It is a hospital. It's a great hospital, but it's mostly.
Former hospital.
Yeah, but they still do like diagnostic.
It was a curious question. Talk to you later.
I was familiar.
Thank you.
Oh, I used to be a friend with Dan Mann's.
Right. And we were just talking about,
So the facilities are probably not so bad. As soon as you get in it,
Yeah, so
you
then-
understand it's not going to be the hospital.
Actually, I almost my first job with you guys a bunch of years ago. My wife, it was some job in Montpelier,
To form that initial.
yeah, and then we were to do that, she was like very clean the city up.
Right.
We have a house,
And not with those
about an
presentations.
hour east of here, just on the North Bennington border. So we spent a lot of time there. Just
quick question.
Decipher which service provider was actually working. And like, literally, I had my buddy on one side, we're like just going through every state.
So, very,
So honestly, the responsibility to have,